What's your age at present?
I'm 67 at the moment, Dr. Haldar.
Okay. And do you have any other comorbidities?
So I have high blood pressure, and Dr. Haldar, again, my physician at CMRI, has found it very difficult to control my blood pressure. I was previously on 2 tablets. Very recently, a 3rd tablet has been added in, but I still continue to get these spells of high blood pressure in the morning. That's when I have the headaches. So the blood pressure still troubles me. I do not have any other medical problems for which I need to take tablets.
So you don't have diabetes, you don't have any metabolic syndrome. Okay, so a patient presenting with drug-resistant hypertension, 80% of them having obstructive sleep apnea, and in diabetes, the prevalence is around 70% if the patient is obese. In recurrent atrial fibrillation, it is more than 50%. So in these cases, you have to think about whether the patient is having obstructive sleep apnea. So you have told your age is 65, and do you have any other family history of having obstructive sleep apnea?
So I'm not sure about obstructive sleep apnea, but I don't have any family member who has this snoring related problem, Dr. Haldar.
Right. And what is your BMI or that weight and height? Can you tell?
So my BMI is 23, Dr. Haldar.
Okay. So in that sense, you are not obese, but still you are having symptoms of obstructive sleep apnea. Are you addicted to something like alcohol, smoking?
So I don't smoke at all, no tobacco use, doctor, but I do drink socially maybe once or twice in a month. That's about it. So social drinking, I'm not addicted to anything.
So have you felt that when you drink during the weekends, your symptoms get worse?
So you're absolutely right, Dr. Haldar. The night I would have a drink or maybe 2 drinks, I would wake up in the middle of the night, and also in the morning, I would feel more tired, more lethargic, more sleepy, and I would also have a headache which is worse on those mornings. So after a drink, that's why I avoid drinking. I've almost completely stopped, and I think I should probably stop completely.
So the risk factor for obstructive sleep apnea is increased age. More than 65, it proportionally increases linearly. And obesity, any obesity, Indians have obesity when the BMI is more than 25. So obesity increases the chance of having obstructive sleep apnea. Male gender, positive family history, and any addiction increases the chances of having obstructive sleep apnea. Next, please. So let me examine you, Mr. Dhar. Please allow me. So can you say this is the torch light? Okay. So your Malampati is 2/4. So Malampati is a classification we do in obstructive sleep apnea to see the upper airway cross sections. We also see various other things, like we see the dental overjet, where the incisor teeth is forwarded more than 2 millimeters than the lower incisor, and that suggests patient have a lower maxilla or mandibular volume. We also see the tonsillar, whether it is tonsillar enlargement or not, because in children, the most common cause of obstructive sleep apnea is bilateral tonsillar enlargement. And we also see the size of the tongue. If you see serrations of the teeth by the side of the tongue, that suggests patient has a large tongue, and that large tongue can fall back during sleep, and that can cause obstructive sleep apnea. So these are the important things. So you don't have a Malampati of you have a Malampati of class 2. It's not great. And let me see what we can do for you. These are the symptoms of obstructive sleep apnea, and we actually need to. Okay, that's okay. Need to do a polysomnography for you. Okay.
What's that, doctor?
Yeah. So polysomnography is a sleep test where we attach several of the channels during sleep. But before going for the polysomnography, we have to determine what level of polysomnography you have to do. For that, we use a screening questionnaire that is called Stop Bang questionnaire. Okay, so these are the screening questionnaire based on 8 parameters. Each positive point has a 1 point. So let me ask you, you snore.
I do, doctor.
That means point 1, plus 1. You are tired.
I am tired throughout the day, doctor.
Plus 2. And if somebody has observed you choking during sleep.
My wife has, yes.
So you have plus 3. You have a blood pressure.
I do. I take 3 tablets.
So you have plus 4. Your body mass index is less than 30. For Indians, we take it 30. So that means 0. So already plus 4 and then 0. Then your age is 65. That means another plus point. That means 5. Your neck circumference is less than 40 centimeter. That means this is 0 again, and your gender is male. So overall your score becomes 6. If the score becomes more than 5, then we can go for a limited channel study. But if the score is lower, then you have to go for a full polysomnography. Here is one caveat is there. If we suspect patient may have any other cardiorespiratory disorder, or if the patient may have any other sleep problems, always the gold standard is a level 1 of polysomnography, which is done at our lab or in any lab.
So when you say level 1, doctor, are there other levels of sleep studies also?
Yes, there are 4 levels of sleep study: level 1, level 2, level 3, level 4. It will describe what are the channels measured in level 1 versus level 3. Practically we do either a level 1 or a level 3. Level 3 can be done at home. In level 3 we have a limited channels. We do not measure the neuro channels, that means the brain waves, the electromyogram, the electroocculogram. These are not measured, and that will be dealt in the next section. So you will have a level 1 study, because I think you are not a typical phenotype of obstructive sleep apnea. Still you are having this symptom. So let us explore whether you are having any other sleep disorder or not.
So when you say not the normal phenotype, you mean I'm not fat, I don't have a thick neck, right, doctor?
Right.
Okay.
And in Indian patients we have seen 40% of the Indian patients are non-obese OSA actually. Well, the global prevalence is much lesser than that. So Indians, in spite of being non-obese, may have obstructive sleep apnea. So I will introduce to Mr. Devdeep Shen. He is our lead technician and our hospital. He will take you through the journey of PSGF, what is and how it is done.
Thank you, Dr. Haldar. Thank you. So while we are swapping seats, you heard what Dr. Haldar said. We are starting off with measuring symptoms. You heard what the symptoms are. Then there's an examination which is mainly looking at the neck circumference and looking within the mouth for the Malampati score. He did the stop band questionnaire with me, which tells you the possibility of sleep apnea. And now he's got our senior technician, Mr. Devdeep Shen, to ask me questions about polysomnography and then the treatment.
Hello sir, welcome to our sleep lab. So are you tensed?
I'm a little tense. I don't know, Devdeep, what they're going to do to me. I have never heard of this sleep study. I've only read in Google. So I'm a little tense, but yeah.
So just relax, so nothing to worry. I will attach some sensor in your entire body, so which is completely painless. So this is our sleep lab. So sleep room is completely different from our normal hospital room. So the room is situated, where the room is situated, that place is completely noiseless. The room temperature is well controlled. The bed is wooden bed because of avoiding impedance during recording time. So let's start, sir. Now I will hook you up.
Okay.
So before doing hookup, I will explain you little bit. So in the total hookup process, I will divide into 3 major segments. One is neuro segment, second is respiratory segment, and third one is cardiac segment. So in the neuro segment, I will put some sensor in your head for doing electroencephalogram, for detecting your brain activity during your sleep. Some sensor attached for doing electrooculogram, for detecting eye movement. Some sensor attaching for electromyogram for chin and leg, for detecting sleep disturbance, abnormal leg movement during sleep. In respiratory segment, I will attach one nasal cannula in your nostril for detecting breathing pattern during sleep. And also I will attach one finger pulse oximeter for detecting oxygen desaturation during sleep.
So, Devdeep, with all these leads, will I be able to sleep? I see this gentleman sitting straight up. Will I be able to sleep with all of this?
Yes, yes. So very lightweight, everything is very lightweight and be comfortable. And the cardiac segment, I will attach just only ECG sensor for detecting heart activity, heart rhythm. But other than these 3 three major segments, I will also attach two more channels. One is thoracic belt, another one is abdominal belt for detecting thoracic movement and abdominal movement during sleep. So after completing the hookup, you will might like this.
Yes.
Okay.
Yes.
So I think.
Okay, so you do your hookup, doctor. I am ready.
Okay.
And let's have the sleep study.
Thank you.
Now, after 48 hours, patient came with the sleep report. So, Mr. Dhar, we have your sleep report. You can see there. So, these are the various channels we have measured actually. And what we can see that during sleep, you are having a complete pause of breathing. That complete pause of breathing actually causes a desaturation. So, your saturation is going from 98 to somewhat 81% during sleep during these apneic events. Apnea means you are having complete cessation of breathing during sleep, and this is being repeated several times during sleep.
So this is when I choke, doctor, when
Yes.
his saturations drop, as you
Yes.
said.
That time you feel a sensation of breathlessness. Sometimes we wake up and we can see every pausing episode or apneic episode that is actually causing arousals in the brain. Your sleep gets fragmented. So the next one. So your AHI is around 35. Any AHI more than 30 is severe.
What is AHI,
So
doctor?
now AHI is apnea hypopnea index. Apnea, you know, complete cessation of breathing. Hypopnea, partial cessation. So that means every 35 times per hour you are having these events during sleep. And for that, you need a machine to wear during sleep. That is called a positive airway pressure machine. But before that machine, we have to titrate you to find the pressure which will abolish all these inspiratory flow limitations.
So what I understand is this machine will keep my breathing passage open. Is that
Right.
what it's going to do?
It is like a splint. It is going to blow air, and your airway will be open so that you will not choke during sleep. So we can have a manual CPAP titration at the hospital itself, or we can go for a auto-PAP titration at home for 7 days. And for you, I think auto-PAP titration will be as good as the manual titration.
At home, you mean,
Yeah.
doctor? That is much better for me. Thank you. Yeah.
And okay. So these are the masks. Devdeep will tell you what are the different type of masks we will use during this titration.
So this is CPAP machine, and this is the interface. So different type of interface or mask are available in the market, but we are using mainly three type of mask. This is oronasal mask, another one is nasal mask, and this is nasal pillow. So nasal pillow is very comfortable. This is advanced mask. So claustrophobic feelings are very less in this mask. So you use this machine for 7 to 10 days, and after.
So this looks very cumbersome. So Dr. Haldar, also question for you and also for Devdeep, looks very cumbersome. Are there no other options that I can have? Is there nothing else that I can do?
So the main treatment of obstructive sleep apnea is always CPAP. And apart from it, you can have some other lifestyle factor which are the adjunctive treatment. The primary treatment CPAP and the adjunctive treatment are weight reduction. Positional therapy, that means you sleep in the supine position, not in the supine position, in the lateral position. There are several gadgets available for that. Surgery is the last option because it is
and him is general surgery, and he is now in Calcutta. You are in Calcutta or?
Multiple times I've come.
Okay, thank you. Please proceed.
This session is supported by Vedanta Group of
Please
Hospitals.
proceed, please.
A very good afternoon to all my seniors and dear colleagues. First of all, I would like to congratulate the organizers and thank them for inviting me for this presentation. I will be talking today on robotic donor hepatectomy, a way forward in living donor liver transplant. So I'll be covering briefly about our team history, then I'll be covering on liver disease, what we do in liver transplant. Yeah. So I'll be talking briefly on our history, team's history, then I'll be touching briefly on liver disease, liver transplant, what we do in that, and then we'll be proceeding and dwelling into the robotic liver surgery. So this is our team. Dr. Soin is there, and I am there on the console. This is our big team from Vedanta, Gurgaon. So our team in Vedanta, so we have multiple firsts to our credit, like first successful cadaver liver transplant was done by Dr. Swine, our team in 1998, then first left lobe, first right lobe, combined liver kidney, and so on. So we were the frontiers in liver transplant right from the early 2000 and till now. We have been one of the largest number of robotic donor surgery done at our center. So, liver disease, what are the common causes of liver disease, cirrhosis, when patient has? So, patient who has chronic viral hepatitis, most common hepatitis B, C or D, alcohol associated liver disease. Nowadays, this NASH that we call in short, that is non-alcoholic fatty liver disease, that happens because of the junk food, sedentary lifestyle and no exercises. Cirrhosis can happen because of the autoimmune. It can be primary or secondary biliary cirrhosis or hemochromatosis or Wilson disease. Liver failure can be acute, and the most common causes is hepatitis A virus and E virus. So that happens because of contaminated food or water intake. So that is fecal route, and the other common causes are delete. So drug-induced liver injury. So the common drugs are like ATT drugs that comes under it, isoniazid, rifampicin. It can be autoimmune, toxins and cryptogenic. So the stigmatas of liver disease is you will be having jaundice, patient will be having hematemesis, that is blood in the vomiters. He will be having a huge tummy with ascites. There will be caput medicae. Patient will have hepatic encephalopathy. He'll talk irrelevant. The sleep pattern will be changed, like he'll be sleeping during the daytime and then awake during the night time. Behavioral changes would be there. So these are the common symptoms of chronic liver disease, and there will be generalized fatigue, weight loss. So once the patient develops chronic liver disease, so it's not like every patient with chronic liver disease, they will need liver transplant. So during the early stage of chronic liver disease, we call it like a compensated cirrhosis. When there is no jaundice, there is no ascites, your albumin levels are good, about 3.5, and overall the patient is, you can't make out that this patient has got cirrhosis, but they will be having small minute symptoms like fatigue, tiredness, loss of weight, nausea, vomiting. Non-specific, but some symptoms would be there. But when they go from compensated cirrhosis to decompensated cirrhosis, so then they start developing jaundice, ascites, hepatic encephalopathy, acute kidney injury. So when they reach this stage, that is the time when we start calling them as a end-stage liver disease, and they need liver transplant. So these are the scores that are used to categorize these chronic liver disease patients into child A, child B and child C score. Child B and C are the patient who need liver transplant. So there are two options. It can be cadaveric liver transplant or living donor liver transplant. Because of the shortage of cadaver organs in our country, the main stream of liver transplantation is living donor liver transplant. So what do we do in liver transplant? So we take out the 50 to 60% of the donor's liver, who is the relative, and then we remove the whole of the liver of the patient, that is recipient, and we implant that into the recipient. So the liver of donor as well as the recipient, both liver, they regrow to the normal size of 90 to 100% in 2 to 3 months in both donor and recipient. So recipient, they have 90 to 95% chances, and if the patient is sick, ICU, bedridden, multiple hospitalization, then the risk factor is around somewhere 80 to 85% survival after liver transplant. And donor surgery, 99.9% is a safe surgery, but as we all know, end of the day, it's a major hepatectomy surgery, so 0.1% chances of things going south. So the common queries that can come of living donor liver transplantation. So who can be the donor? So the donor has to be relative to the recipient. The age should be 18 to 55 years, and the blood group, either it should match the patient's blood group or it should be O. Plus minus doesn't matter. So roughly donor needs to be staying in the hospital for 5 days, and recipient would be hospitalized after surgery for 10 to 14 days. And donor can resume the normal life after 15-20 days. Recipient can resume the life after a couple of months. For donor, there is no lifelong medicine, and for recipient, the person who is undergoing liver transplant, after a couple of years, there will be 1 or 2 medicine that they have to take lifelong. So life expectancy is as much as without the liver disease. If the person has to live 80 years, they can live that much of years with that new liver. So now coming back to the main topic of robotic donor hepatectomy. So as the name says, it doesn't mean robot operates. It's the surgeon who operates the robot and then the surgery is being done. The advantage of this robotic surgery is the scar mark, wound related complication, there is no hernia, there will be faster recovery, pain would be less, and because of these things they can return to their normal life bit early. But having said that, there is a cost of 4 to 4.5 lakh extra in liver transplant if you want to go for the robotic surgery. But one thing I can say, it's much better than open and laparoscopic surgery. Our program is one of the largest program all over the world, with 502 robotic cases done at our center, liver surgery wise. So this is the robotic OT setup. Here you can see the surgeon is sitting on the console, and with these joysticks he is operating, and this console is attached to the patient cart side. These arms are there from where the instrument goes inside the abdomen, and one surgeon sits at the patient side and then the main surgeon operates on this. So this is how the robotic surgery in liver happens. So way back of liver transplantation, minimal invasive surgery. So first laparoscopic surgery was done in 2002 in France, and then slowly it reached to robotic in 2016, and after that there are a handful of centers who are doing robotic surgeries in liver. So why we need minimal invasive donor hepatectomy? Because the major morbidity rate is because of the scar that is there in the open donor hepatectomy. 25 to 40% of the patients who undergo donor surgery, half of the liver is taken, so they are left with the scar, wound related complications and infections that can cause them worry. So robotic surgery, it mirrors the open surgery. So that means the robotic instruments, they have got a wrist same as we have the instruments, because laparoscopy, it's quite rigid. Laparoscopy instruments, they do not have wrist and elbow movement, but in robotic it has that. The magnification is 10 times as the naked eyes, so you get a magnified 3D view. It filters out the surgeon's hand tremors, and there is a steady retraction, and it's quite ergonomic. You are just sitting on the console comfortably and operating this difficult surgery. So these are the all advantages of the robotic surgery, which gets reflected in the outcomes of the donor surgery. But definitely the issues with it is cost, availability and training of the robotic surgery. So this is our experience at Medanta. We have done so far 502 robotic cases, out of which total robotic donor hepatectomies we have done 492. Averagely we do 14 to 15 robotic donor cases every month, and average time console robotic surgery time is 5 to 6 hours. And we accept all comer donors who are willing to undergo robotic surgery. And this is couple of our literature we have published from our center based on our experience in robotic donor surgery. This was published in 2024 of our technique of duct division in this, and this was published in last year American Journal of Transplantation. Our complete series was published. So this is a surgical scar that you get in a normal conventional way. Here you can see a big reverse L incision is there. If you go for a midline open surgery, so this is a scar, and you can see here robotic surgery, these small 8 mm scars are there, 5 scars and one 5 to 6 mm scar here. So eventually with time these scars you won't be able to see, and it becomes like you can't identify this person has undergone any kind of surgery. So this is the beauty of robotic surgery with a better outcomes. So as we have time, I'll just show you this short video of my case where we did robotic surgery. So this is the robotic instruments that has gone inside the abdomen. This is what I was saying. So the instruments have got wrist. You can fold your wrist accordingly, and like how you do in your with your open surgery with the hand. So this is the right lobe of the liver that we are mobilizing, and in this surgery we are taking the right half of the liver from the donor, and we are going to give this right lobe to the patient. So this is IVC that is attached with the right lobe of the liver, and there are small veins that are draining this right lobe of the liver. To take out this right lobe of the liver, we have to deal with these small vessels, we have to divide it. Sometimes if these vessels are bigger like this one, so then we'll have to do anastomosis of these vessels in the recipient side. So we divide it with the clips. So this is the main outflow blood that drains the liver, that is right hepatic vein. So after mobilizing the right lobe of the liver, doing IVC dissection, we go back on the porta side, we do gallbladder surgery as conventional cholecystectomy. So this is the portal vein. So portal vein has got two parts, right and left, and this liver we are going to take on the right side. So right portal vein we need to loop, so that later when we are ready to take out the graft, we'll divide this right portal vein. So this right portal vein blood vessel is looped. So after looping the right portal vein, this is the right artery that we have dissected around, and we'll be dividing it. So in the CT, picture-in-picture CT image, you can see in this patient, we have got single right hepatic artery.
Dr. Yadav, 5 minutes left.
Yeah, so I'll be finishing on time. So right after looping the portal vein and artery, here we can see the biliary confluence. So we'll define the biliary confluence. Biliary confluence is formed by the right and left hepatic duct. So now we are going to divide the liver into two halves according to the anatomy, into the right and left. So while doing the liver transection, we apply stay sutures. So this is the MHV recon of the CT scan, which shows the multiple veins that we are going to encounter when we start dividing the liver. Because with the naked eye you can't see these veins are hiding inside the liver parenchyma. So for that thing, you need to have a better understanding of CT scan. You need to sit down with your radiologist and understand where you are going to encounter these veins. So this is the first vein that would be draining the segment 5 that we have encountered. So as you can see in the picture, this is the vein that we have encountered. So because we need to take out the right side of the lobe liver completely, we are going to divide these veins one by one as and when they come in the transaction. And when we take out this liver on bench, we are going to open up these hemolocks clip that we have applied, and we are going to reconstruct it with the Dacron graft and then put the anastomosis accordingly. And in robotic surgery, the main learning curve is because of the transaction that we are doing of the liver with the harmonic. So this is the other vein that we have encountered. You can see this is the major blood vessel draining the segment 5 and 8 of the liver. We have looped it, applied hemolock, and then divided it. These all veins we have to reconstruct. So now we are dividing the caudate lobe of the liver. That will free it completely from the parenchyma vise. So lab CUSA we use sometime in between for the hilar plate dissection, and for the remaining part of the liver transaction, we pass this Riles tube across the liver parenchyma so that we can lift it up from the IVC, and when we are dividing it, we are not injuring the IVC. This is the last vein that we have encountered in the liver parenchyma.
Please finish up, Dr. Yadav.
Yeah, I'll be finishing up. This is. So I'll just skip it and. So yeah, so here we can see this, now the liver graft is ready in the donor. We are dividing the right artery here, then we'll be dividing the portal vein and take it out in a bag that is placed already. Here you can see this is the endo bag that we have placed, and the whole of the right lobe is placed in that. Yeah. So this is how the MHV we have reconstructed. So these were the veins that we encountered. So 1, 2 and 3, those we have reconstructed with the Dacron graft, and we'll be doing anastomosis of those. Thank you.
Thank you, Dr. Yadav. Thank you, Dr. Yadav. Please come down to the selfie zone. Please come down to the selfie zone to receive your memento from Dr. Mrs. Panchali Rai, Executive Committee member of the FPA Family Physician Association, Kolkata. Dr. Mrs. Rai is also the better half of the organizing chairman, Dr. M.H. Sanwarwala. Big round of applause for Dr. Kamal Jadhav as he receives the memento from Dr. Panchali Rai. Now, Dr. Shakil Akhtar to proceed with the next session.
I will invite Dr. Sanjay Shah to present a paper on prevention of shingles in comorbid conditions. Dr. Shah is an around. He is a senior consultant at Narayana Hospital. You must be astonishing that he is presenting an unusual paper, but it is linked to the comorbid conditions of the patients. So he has been given this task to deliver on the shingles, prevention of shingles in comorbid condition. Thank you, Dr. Shah, please.
Right. Thank you, chairpersons, for that kind introduction. Thank you to all my colleagues who are attending this afternoon. A special thanks to FPACON for inviting me, and in person, thanks to Dr. Gala, I know personally, Dr. Jasani, I know personally, Dr. Gulgulia, okay, Dr. Savarwala, I know personally. Thank you all. It's a great opportunity to meet you here today. You've heard you can do exotic things for patients who are not well. What I'm going to basically talk is something about what we all can do to keep our patients well. Okay, so the tables have been turned. So it's what we are managing is wellness rather than illness, is what we are going to try and do for the next 15 to 20 minutes. I'm not a GSK employee, but I must thank GSK for bringing a very effective Shingrix vaccine, which is an adjuvant herpes zoster vaccine for the management of adult vaccination to prevent shingles in patients with diabetes and comorbid conditions. So that's the talk that I'm going to give this afternoon. Herpes zoster, the impact of underlying comorbidities. Herpes zoster and diabetes mellitus, which is so close to my heart. Zoster and COPD. Zoster and cardiovascular disease. And I'll end with Shingrix vaccine, its efficacy, safety and recommendations. So the introduction is that I'm sure this august audience is aware about herpes zoster. It is predicted to continue to increase because of presently a growing burden in the population at large, largely because we are all going to age more, we are going to make our patients live longer. Aging actually provides the bedrock for immunosenescence, okay? Our humoral and innate immunity actually wanes with age. And as a consequence of that, at a particular age, particularly more than 50 or 60, we generally tend to have more infections. And we are now talking about, just as we talk about vaccination in children, we are talking about vaccination in adults. So as you can see on your right-hand side, age and immunocompromising conditions. And immunocompromising conditions are well-recognized risk factors. This is largely because we have become very good at even managing serious illnesses and making live people longer with autoimmune disorders like malignancies as well. Malignancy today has now become a chronic disease. So such is the scenario of modern medicine that we now have to tackle and prevent infections which can be harmful to our patients. Herpes zoster is characterized by acute pain to begin with usually, and then you tend to get vesicles erupting in specific dermatomes. It infects the quality of life, so pain precedes the vesicles, and the common complications which we actually battle with is post-herpetic neuralgia in nearly a third of your patients, and sometimes it can be very serious, like herpes zoster ophthalmicus, where you can actually have sight-threatening infections from herpes zoster. And this can be also very expensive as well to treat. So herpes zoster incidence has increased in several countries as we all are aging a lot more throughout the world. Medical science is getting better and better at making people live longer. So what are the other risk factors apart from aging? The comorbidities is diabetes is one, very close to my heart, COPD, cardiovascular disease. So you have a nearly 30% increase in basically having herpes zoster because of patients having diabetes, COPD or cardiovascular disease, and then with increased use of steroids, be it for COPD or otherwise, as well in patients with malignancy on chemotherapy as well, the risk of actually developing herpes zoster goes up 6 to 10 times. And any injury, including surgical injury, increases your risk of developing herpes zoster up to 10 times. So autoimmune disease, I've mentioned already, malignancy, HIV, and during the COVID-19 epidemic as well, we've seen more patients with herpes zoster than ever before. So even COVID-19 infections, and then psychological stress also basically forms a great milieu for patients to develop herpes zoster. So these are some of the comorbid conditions which result in herpes zoster infections, increased risk. Now, each comorbidity increases your risk, and if you have more than one comorbidity, as you can see on your right-hand side, if you have diabetes, your risk increases by nearly 20%. If you have diabetes and heart disease, it goes up further. So on your right, here you are. So there's, with every increasing in comorbidity, your risk of developing herpes zoster actually continues to increase. And that's the reason why perhaps avoiding or trying to prevent herpes zoster is extremely important to give our patients a better quality of life. Not only do you manage to avoid, but you can also give it to people who have had herpes zoster. Okay, you can actually prevent herpes zoster recurrence. So the recurrence of herpes zoster is more likely in patients who have these comorbid conditions, those who are more than 50 years and above, with say diabetes, with CKD, with dyslipidemia, with hypertension, with ischemic heart disease. Your risk is increased significantly, as you can see here. And even if you have a history of herpes zoster, giving them this new vaccine, which is a subunit vaccine, okay? It's a subunit vaccine, adjuvant vaccine, which actually prevents the recurrence of herpes zoster as well as post-herpetic neuralgia. So again, that basically features that it is something which is useful to use in our patients who are 50 plus or 60 plus to prevent them from herpes zoster. So let's look at some data with respect to herpes zoster and diabetes. Now, diabetes is a state of increased inflammation. It also impairs the immune system, and that perhaps provides the bedrock for increased risk of herpes zoster. The reduction in cell-mediated immunity and innate immunity, okay, dysfunctional innate immunity actually results in increased risk of infections. So the diabetes with long-term hyperglycemia results in effects on the polymorphonucleus cells, increased apoptosis, increased inflammation. You also have diminished innate responses from polymorphonucleus cells, monocytes and macrophages, as well as disordered humoral immunity because of significant hyperglycemia. As we all say, even in hospitals, we want to keep our patients' blood sugars anywhere between 100 and 180. Why 180? The 180 is largely, to anything more than 180 affects the white cells from doing its proper function. So it's good for wound healing, and it's also good for reduced, basically, infection rates in hospital as well. So that's the reason why. The same story is what I'm showing here in terms of trying to provide protection for our patients from herpes zoster in patients with diabetes. So there's a good reason why we should consider using herpes zoster vaccine to prevent this condition in patients with diabetes. Now, the data is fairly large. If you look at several meta-analysis here from Kawai 2017 global, and then you have from Mara 2020, again global data, you can see population studies in type 1 and type 2 diabetes patients. You have a pooled relative risk increase in herpes zoster anywhere between 1.25 and 1.3. So more than 20% increased risk of herpes zoster is observed in patients with diabetes, and herpes zoster contributed to the deterioration of glycemic control as well. So diabetes increases herpes zoster, and herpes zoster increases the risk of you having poor glycemic control and perhaps even increased hospitalization as well as a consequence of herpes zoster as an illness. So higher health care consumption and costs to therapy. So the impact of herpes zoster on patients with diabetes have a higher risk of post-herpetic neuralgia as well. And this may impact even glycemic control. So as you can see on your right hand side here, you have elderly people more than 50 to 79 years of age. The risk of post-herpetic neuralgia in patients having diabetes compared to non-diabetic is 1.7. So nearly a 70% increase in post-herpetic neuralgia when it comes to complications of herpes zoster. So patients with diabetes have an increased risk of persistent post-herpetic neuralgia compared to those who do not have diabetes, and this condition itself also negatively affects glycemic control. And then you understand that the poor glycemic legacy has its own effects, okay, in terms of cardiovascular and kidney outcomes in patients with diabetes. So it's becoming increasingly important to prevent certain infections, which we can do very effectively today in 2025. So that brings me to herpes zoster and COPD. The COPD again is a condition of chronic inflammation and immune dysregulation. These patients also have a high risk of herpes zoster, and then you have decreased cytotoxicity of the peripheral blood NK cells, natural killer cells. We've already heard about the effect on monocytes and polymorphonuclear cells as well. So significant dysregulation of the innate immunity. But the additional problem in COPD is patients are treated with steroids, be it inhaled steroids, be it oral steroids or IV steroids. And that itself, steroids itself, increases your risk of basically immune suppression as a consequence because of reduction in inflammation, and that also results in an increased risk of herpes zoster. So here is data with respect to COPD and herpes zoster. Patients taking inhaled corticosteroids are more likely, so your hazard ratio goes up from 1.67 to 2, and if you're taking oral corticosteroids, up to 3. So COPD patients using inhaled or oral steroids at a greater risk of herpes zoster infection. And patients with the same condition also have an increased risk of post-herpetic neuralgia, which is very disturbing and really affects quality of life for our patients. Let's move on, and we'll briefly talk about cardiovascular disease. Now, herpes zoster and cardiovascular disease, there is actually an element of vasculopathy as a consequence of herpes zoster infection. So it's a prothrombotic phenomenon. You have increased risk of stroke and myocardial infarction. You also can have a VZV, varicella zoster, a virus reactivation in sensory and autonomic ganglia as well. So you have increased risks of even arrhythmia, increased risk of atrial fibrillation, even myocarditis for that matter as well. So these events are actually increases subsequent to a herpes zoster infection. The data shows that herpes zoster is linked with 1.35-fold increase, so a 35% increased risk of myocardial infarction within the initial 30 days of post-infection. You have also increased risk of myocarditis as well as atrial fibrillation, as I have mentioned earlier. This is data, again, huge epidemiology data, largely showing the effect of herpes zoster and the follow-up period. So your hazard ratio for the adjusted hazard ratio for coronary artery disease, up to 5 years, so 2 years and 5 years, your risk actually is significantly higher, roughly about 1.2 times, okay? So after 5 years, well, it wanes, the hazard ratio doesn't it drops back to the control group, but the first 5 years show increased risk of cardiovascular disease events in patients who actually get herpes zoster. So, how can we tackle or avoid somebody from getting herpes zoster? Shingrix is a new vaccine. We used to have a zoster vaccine in the past, which was a live attenuated vaccine, but this was not very effective. Shingrix is an adjuvant mediated, basically a subunit vaccine. The subunit is glycoprotein E, okay? And that's what Shingrix vaccine is. We'll next look at some of the efficacy and safety recommendations. Glaxo did 2 studies, Zoster E50 and Zoster E70. This was in patients who were 50 years of age and those patients who were 70 years of age. Now it was a randomized, observer blind, placebo-controlled, multi-center, multinational study, and they gave it, you're supposed to give 2 injections, okay, 0.5 ml IM at 0 months and 2 months, 2 months apart, okay? And what they looked at was essentially the efficacy in terms of preventing herpes zoster and the efficacy in preventing post-herpetic neuralgia, okay? And there were roughly about anywhere between 15 and 16,000 patients in each of these studies. And what it showed quite nicely, that it was more than 90% effective. So we have never had such an effective zoster vaccine in the past. More than 90%. In fact, for more than 50 years of age, 97% effective. Okay, extremely effective. Okay, and in patients for more than 70 years of age, more than 91% effective. So a very effective vaccine that we have in Shingrix for patients to prevent herpes zoster infection. And not only during the trial, which was about 4 to 5 years, that even the effect continued to last even for another 5 to 7 years. So this is 11-year data. So this is zoster E, 50 and 70 years of age. This is long-term follow-up extension study till for another 6 years. Even after another 6 years, so more than 10 years, the vaccine is still effective. It reduces your risk of developing herpes zoster by nearly 80%. Okay, so that remains very, very effective. So throughout its course, after your first injection, okay, over the term of 11 years, it is effective in 87% of people. So it's a very effective zoster vaccine, Shingrix, in clinical practice. That is Western data. What about Indian data? And here is basically showing you the Indian data in 288 Indian subjects over a period of 8 months. Obviously, they haven't looked at such long data, but 2 injections, 2 months apart. They looked at vaccine response rate, nearly 86%. And what they also looked at was looking at anti-GE humoral response, okay? The geometric mean concentration was nearly 20 times. So very effective antibody or T-cell mediated sort of effect as well with the use of herpes zoster in Indian patients.
Sir,
That brings me to what the global guidelines say.
2 minutes left.
2 minutes it will be, sir. The global guidelines recommend the CDC, the ACIP, the ADA, the American Diabetes Association, GOLD. This is essentially for obstructive lung disease. Then the CDC. If you look, all of them recommend the use of using the Shingrix vaccine in more than 50 years of 50-year adults. Okay, 50. So 50 plus is the standard recommendation. And if they have been vaccinated in the past by the previous vaccine, the sort of zoster vaccine, even then you can vaccinate this with this new vaccine. Okay, even in previously vaccinated cases, because this vaccine is far more effective than the previous vaccine that we have. If you look at Indian consensus guidelines, the API, the RSSDI, the Geriatric Society of India, the Cardiology Society of India, and the Indian Medical Association also perhaps says that you should give 2 doses for patients who are more than 50 years of age. Now, Shingrix vaccine is given in 2 doses, I mentioned. Okay, it has to be reconstituted. Do not freeze this vaccine, and you have to give them intramuscularly. Okay, Shingrix is not indicated for the prevention of chickenpox. Remember that, the primary varicella infection. The primary chickenpox actually you have to avoid by giving the chickenpox vaccine is the Varivax vaccine. For Shingrix, this is different. This one actually stimulates only T-cell mediated immunity, while the Varivax vaccine basically stimulates both humoral and T-cell immunity per se. So that brings me to my last slide. You can give this vaccine along with influenza vaccine, with the pneumococcal vaccine, as well as with basically tetanus and diphtheria vaccine as well. So that brings me to the end of my talk. Thank you for your patient hearing.
Thank you, Dr. Shah.
Thank you, Dr. Shah. Please come down over here to the selfie zone to receive your memento from Dr. R.B. Leela, past president of the Family Physician Association, Kolkata. Please come down over here. Dr. R.B. Leela to present a memento to Dr. Sanjay Shah. Loud round of applause from the audience. I hope you haven't got sleepy. Please make your presence felt by the loud round of applause. Dr. Shah receiving the memento from Dr. R.B. Leela, past president of the Family Physician Association. Meanwhile, I request Dr. Shakil Akhtar to call the next speaker.
I would like to invite Dr. Akhilesh Agarwal to talk on amputation. Is it an end of road?
We are very proud that Akhilesh Agarwal is a member of our Family Physician Association, and this one session is not supported by any industrial house. It is self-supported. Dr. Agarwal has come up with the self-support in favor of the Family Physician Association.
He is an eminent plastic surgeon working at different hospitals of Kolkata, Manipal, Dakuria, Bellevue Clinic, and he has received lot of achievements in his life career. I will request him to please start with the topic and finish it up in 20 minutes time. Thank you.
Good afternoon, everyone. We have had long association with FPA, and I'm mainly a trauma surgeon, and nothing can be more traumatic than an amputation. So a patient having an amputation, is it at end of the road for him? Today the era is very fast moving. Accidents do happen. Can be due to automobile accidents, can be machinery, working in factories, can be at home using home appliances or door crush, etc. Or can be on foolishness. I have put this because majority of my amputation patients, they are youngsters. Despite having lots of brushes in the market, they like to clean the chain of their bike by the hand and end up having an amputation of their fingers. So that is why I have put out this. Most devastating injury is amputation of any body part, which leads to trauma, which can be physical, because it leads to handicap, psychological, because it causes an incomplete body image, occupational, definitely a person who becomes handicapped has an occupational handicap as well. So what to do? Shall we leave them to the fate, which the patients will end up like this, or shall we follow what Jesus said? Do not leave them to the fate. You must be the one who does the resurrection. So starting with thumb reimplantation, commonly found in the workers, and unfortunately the amputations of upper limb are more commonly found in the underprivileged lot of our society, mostly the workers or the youngsters, as I have mentioned, the bike chain riders, etc. So he was taken immediately for the reimplant. The principles of reimplantations were followed, and this is the result we get after 4 months. Almost normal function, carrying out his daily activities, can't make out whether there is any reimplant done or not. He's back to his profession. This is one of the foolish amputations, bike chain. Distal phalanx amputated, reimplantation done, and this is the result we get. This was an unfortunate farmer who also is a bus driver. In a thresher machine, his hand got amputated. Only parts of the amputated part came. These were the parts that came to us. So probably the blue shaded parts were lost in the site of the accident. Here we did a spare part surgery. Because he's a driver, he needs power grip. That means he needs thumb, and he needs a long span, because this is his left hand. To shift gears, he needs a span, and he needs a long ring finger and the middle finger. So what we did an heterotrophic transplantation. Probably what was the index finger, we put it on the thumb, and probably what was the part of middle finger, we put it on the ring finger. And this is how he is. He has got good range of movement, back to his profession, though the hand doesn't look that great, but he is able to carry out his daily activities as well as his profession. He is not handicapped. Kids. It is a touchy topic. We regularly get kids who get their fingers crushed in the door or while playing in the kitchen with a knife. And the blame unfortunately goes on the caretakers. Maybe parents, maybe nannies, maybe whosoever is there, or the elder sibling. So this was a 3-year-old kid who accidentally amputated his right index finger by a kitchen knife. So this was the level of amputation. You can imagine the plight of the parents. So this was the X-ray. We did the reimplantation and were successful. This is how he looks after 6 months. This is his latest picture. We removed the K-wire. The shape is normal. The nail growth is normal. Length, volume, everything is normal. Another 1-year-old kid had 3 fingers amputated. Now they were badly crushed because a load fell on his hand. This is how the kid came to us. So what we did was a GRF by an abdominal flap. It is a stage surgery. And here we got the fingers back, though it doesn't look absolutely like a finger, but he has got the length. And as the kid grows, we have got many other plans that we can do to give the shape and the contour as well as the same skin back. We do have failures. To err is human, but it leads to innovation. We have failed, and this thumb reimplant, who was reimplanted somewhere else, came to us. It was gangrenous. So what we did a toe transfer, partial toe transfer, and this is how it looks, almost like a normal thumb, having the same shape, padding, volume, as well as the look. Also, he has a good new fingerprint, and this is the donor. Can't make out much. Foot reimplants, another touchy one. A young boy who came from Siliguri for exam slipped under the train. So this is how his foot was brought to us. We reimplanted. There was a shortening. Multiple stage surgeries were done. Then Elizarov was done. Now this is the same length. And you can imagine the joy. He came to visit us when we went to Kalimpong with his family. He is walking on his foot without any aid. He is back to his studies, to his college, enjoys all the games that he plays. Another farmer ran over. This is how his x-ray was. We reimplanted. Few more surgeries were done. He can move his foot. Though it's not great looking, but he's not concerned with that. He's back to his profession. He walks without support. He has got good sensation. He's mentally scared now. That's why he kind of, takes small steps. But he's back to farming. And that is the greatest gift we can ask for. Another patient with a foot reimplant. So all these 3 patients, they are back to their normal work after reimplantations. 8-year boy suffered hand amputation while helping his father in his fields. We had reimplanted. This was a recent case, so his physiotherapy is on the way. So our stats till date, we have reimplanted successfully 5 legs and foots, 4 upper limb, 2 at the wrist level, 1 at the forearm level, and 1 at the mid palm level, and more than 350 fingers and thumb reimplanted successfully. Yes, we have failed, but when we work, we are bound to fail and we are bound to succeed. So I always like to look at the brighter side. Ending up, the take home from my side will be reimplantation of an amputated part is perhaps most gratifying way to reconstruct. It preserves the structure, completes the perception of body image, brings back the person to the normal stream of society. There may be debates. Why should we go for reimplantation? Why not just give a prosthesis? But that debate will go on till eternity. Reimplantation is a commitment, both on the part and the patient's part, and both have to be ready for failure. But again, when we work, we tend to fail. So I will end up saying that success is not final, failure is not a fatal. It is the courage to continue that counts. Thank you.
Many thanks for excellent presentation.
Thanks, sir. I am here to take any queries if you have.
No question answer sessions are allowed. Dr. Agarwal.
You can have a talk with our delegates
Okay, sir.
on floor, sir. Thank you
Dr.
very much.
Agarwal,
Thank you.
please come down to the selfie zone to receive your memento from our very own executive committee member, Dr. Krishna Handa. Dr. Krishna Handa to present the memento to our Family Physician Association member. Please stand over there. Please stand over there. Loud round of applause from the audience, please, for each and every speaker. Dr. Handa presenting the memento to Dr. Agarwal. Meanwhile, I request Dr. Shakil Akhtar and Dr. Sopan Mondol to call the next speaker.
I would like to request Dr. Shilpa Bhartiya to please come and deliver a talk on decoding anemia. She is from
she's come from Apollo Gradient Hospital. She is very much, we have heard her presentation before. She is a nice doctor. Please.
She is an hemato-oncologist practicing in super specialty hospital, Parkview and Apollo Grey Eagles. I request you to please start. 20 minutes time allocated. Thank you very much.
Very good afternoon. Namaste all our senior doctors over here. I am Dr. Shilpa Bhatia. I am a hemato-oncologist and I work at Parkview Super Speciality Hospital and I am associated with Apollo. Today we are going to talk about how we decode anemia. As we all know, anemia is one of the most common presenting symptoms, and I think in the general physicians, this is the first thing, the first doctors that you're going to see patients who present with anemia, and it's important to know how we stage our further investigations. So, you know, when I define anemia, we know in women if it is less than 11, it's anemic, and in men if it is less than 12, we call them anemia. So when when I'm talking to a patient with anemia, I'm looking at three things in my head. If I have a report which gives me red cell indices, it very much is helpful in telling whether it is iron deficiency or not. But I'm looking at three main things. Is there a problem in production of the red cells, where there is a problem in the bone marrow? It may be due to hematinic deficiency, it may be due to malabsorption, it may be due to bone marrow infiltration or other aplastic anemias. Or are we dealing with somebody who is having blood loss? That can be an acute blood loss, very heavy period, sudden GI bleeding, or it can be a chronic blood loss where they have hidden ulcers anywhere in the GI tract. It can be in form of malignancy. And let's not forget, worms are one of the most common reason of causing iron deficiency in our country. Of course, we should not forget piles or any other source of bleeding. And sometimes when you don't know what's going on, it's also important to remember that maybe there is no problem in production. You cannot find where the blood is getting lost. There may be hemolysis within the blood system. So then we have a specific group of tests. So instead of going just on a lecture, I'm going to describe a case which we recently saw. It appeared to be very...
But as in Indian context, HPV incidence or prevalence is almost negligible. So we usually deal with staging as the most important prognostic factor in all practical aspects. So this is a common thing that we stage the cancer based on TNM, so tumor, node and metastasis, and by permutation and combination, we declare it as early stage for stage 1 and 2 and advanced stage for stage 3 and 4. So as you can see that stage 1 and 2 only comprises tumors which are less than 4 cm in size without any regional or distant metastasis. So why I am highlighting this? Because stage and survival goes exactly the opposite way in all cancer patients. So these are the SWR database. So as you can see here, that as it tends to localize and gets dispersed into the neck or distant metastasis, so the survival rate, 5-year survival rate drops. So this is as good as lip, same for tongue, floor of mouth, in fact all the laryngeal subsites and hypopharyngeal subsites, same for salivary gland tumors, and all sorts of thyroid cancers, be it papillary to anaplastic. So be it any type of cancer in the head and neck, the only thing that remains static is basically as the stage progresses, the survival drops. So why I am enforcing or reinforcing on stage 1 early diagnosis? Because how does it change the management? So an early stage diagnosis gives us enough confidence to go single modality treatment. A less morbid surgery because of the smaller tumor size, and resultantly early rehabilitation, and obviously it's a single modality treatment, so the cost implication is less to the patient. So as you can see here, this is a stage 4 cancer and this is a stage 1 and stage 2 cancer, and by simply looking at this you can very well say that these two patients will do better when compared to this patient, even after all sorts of rehabilitation. Single modality also helps in reducing the side effects of multimodality treatment when we combine surgery, radiotherapy and chemotherapy. As you can see here, a lot of oral mucositis, and the most dreaded complication that we face is osteoradionecrosis of the jaw. So overall, early diagnosis not only helps in survival but also gives a better quality of life post-therapy. Similarly, this is one of our paper which also says that surgery only gives a better cost effectiveness when compared with surgery versus adjuvant radiotherapy. What additional can we offer to a patient who has got diagnosed with an early stage head and neck cancer? So this term we already know about it. It's called minimally invasive or remote access surgery. So in head and neck cancer, what we offer to these patients, or what we can offer to this select group of patients, are conventional endoscopic surgeries, a robotic surgery, either a transoral or neck, or a laser surgery. So I'll come one by one. So transoral laser microsurgery is basically indicated for early glottic malignancy, laryngeal malignancy, as you can see here. This is one of our patients, or else pre-malignant lesions where radiotherapy does not work. Now the good part about this is a daycare procedure. So the patient comes in the evening, comes in the morning, gets operated in the afternoon and gets discharged by the evening. So this takes hardly 30 minutes with a cure rate of almost 95 to 99%.